You keep hearing about it, no? Right heart failure. What is right heart failure? In medicine, they teach you.
Yes, sir. So there is, since there is right heart failure, there will be pooling of blood in the, firstly in the major vessels which drain into the right heart. So that would cause increased jugular venous pressure. There would be increased pooling of blood in the hepatic veins as well.
So basically, it's about the right-sided failure is about the inflow failure. No? See, there can be various causes which are basically related to the right atrium or right ventricle. It's very easy to understand. The most common being, if you look at one valve, which is going to bother here is tricuspid. The tricuspid wall stenosis as well as incompetence, both. And usually with the back pressure, what is going to happen? The lungs will fill up and also will the liver. So when the liver fills up, it will produce a tender, smooth hepatomegaly. But it is tender, not irregular, surface is smooth. In addition to this, you'll have the raised JVP naturally because the neck veins are engorged. Now, depending upon if it is an incompetence, like mitral incompetence, you will have a pansystolic murmur. And in the left side, with the mitral incompetence, this murmur goes to the axilla. It radiates, no? Why does it radiate to the axilla, Dipra? Why does a mitral incompetence murmur, which is pansystolic, because throughout the systole it will happen. So most people don't want to think about it. What is the usual anatomical relation of atria to the ventricles? Atria are posterior, ventricle is anterior. So the blood flow is from posterior to anterior, but the leak would be anterior to posterior. And the murmur is about the leak or the narrowing. The sound is heard because of that, right? So the leak would happen from the right ventricle into the right atrium. When would it happen? During systole, because when the ventricles contract, the blood is supposed to go forward, where the mitral as well as the tricuspid valves should close, and the aortic and the pulmonary valves will open. That's how the usual system would be. But here there is a leak. The mitral is not completely closed, so there will be a leak back. So therefore there is, the murmur is when there is systole. So it's a pansystolic murmur for this reason. I'll just also explain through this why is it mid-diastolic in mitral stenosis. So mitral incompetence would produce pansystolic murmur which radiates from anterior to posterior because ventricle is anterior, atrium is posterior. Bina band karo dawai. And ventricle to atria. So it goes from front to back. And to go from front of the chest wall to the back, you have to go via axilla. That's why it radiates to the axilla. It's common sense, which is uncommon. So it will radiate, it will be pansystolic, and naturally the first heart sound is caused by the mitral wall. So it will be naturally softer. In stenosis, it is loud because it's going through that jet. Here there is a leak. The whole story is about the blood leaking back from the ventricle to the atria. So it goes from front to back. It is in the systole, throughout the systole, and the first heart sound drops. Especially if there is a right ventricular hypertrophy which happens due to mitral stenosis. The reason is the same, back. The right ventricular hypertrophy will have the left peristernal heave for the same reason. Neck veins are engorged. These are all connected. There's no rocket science in it. It's basic physics or dynamics of the flow of the blood. So abnormal flow of blood produces a murmur, and the direction of that flow creates the passage or the pathway for the murmur. So mitral incompetence, pansystolic murmur, weaker heart, first heart sound, and the murmur radiates to the axilla because that's backwards. Why does it radiate to the axilla? Because the leakage is from anterior to posterior. from front to back. While in mitral stenosis, it is not the, during which phase is the mitral valve opening. In diastole, because the ventricle has to fill up. So the atria contract. And atrial contraction is basically only 30% of the flow. 70% is negative pressure, because it dilates, so it. So in the process, when the blood is going through the mitral valve, there is a jetting effect, and therefore it will happen during what phase? Initial part is taken care of, but middle part is when the atria is contracting. So mid diastolic murmur with the right ventricular hypertrophy, with the left parasternal heave, with the possibilities of the conditions that produce mitral stenosis, the rheumatic fever in childhood. So you'll have the features of rheumatic fever, which, as they say, licks the joints, bites the heart. So it is, arthritis, but heart is rogered, and that leads to the problems of the mitral valve. Because there are problems of the mitral valve which is abnormal now, any bacterial embolus will come and lodge there, produce subacute bacterial endocarditis, which again has a triad, SABE triad. What is that? Clubbing, splenomegaly, and microscopic hematuria. So does it require a separate class for it? This is mitral incompetence, mitral stenosis. Similarly, extrapolated to the right side. Story is just the same. With tricuspid incompetence, what is happening when the ventricle is contracted, the contraction goes back right up to the heart. So it is not just to the liver, sorry. So it's not just the liver which is tender and enlarged and smooth, also pulsatile. So what is the differential diagnosis of pulsatile liver? Tricuspid incompetence, hemangioma of the liver. This is the other one. You make those MCQs out of it, don't you? These are 3 MCQs you made out of it. And there is the engorged neck vein. Remember, the only shock with engorged neck veins is cardiac shock. All shocks will have collapsed neck veins. The moment you see a patient in shock, you're examining, just look at the neck veins. If the neck veins are engorged, it's a cardiogenic shock. In a cardiogenic shock, don't give fluids, you'll kill the patient. In other shocks, you give the fluid so that you save the patient. So you should know where to give IV fluids, where not to give the IV fluids. So it is not possible to be managing your patient with just one-sided unidimensional approach to understanding a problem. Same as it fills up the liver, it fills up the lungs. So you'll have the initial features of Krebs, breathlessness, that is dyspnea. And in mitral stenosis, you may have hemoptysis. One of the important causes of hemoptysis. What is the commonest cause? Is tuberculosis in India. But mitral stenosis, especially in children, is another important cause. Non-pulmonary causes, mitral stenosis. The pulmonary causes, you of course know, pulmonary tuberculosis, bronchitis, lasting bronchitis, and many other conditions. I won't even go there. So they are all connected. So understand the connection, and you know one problem, the other problem is not. The patient was referred thinking it's a hepatomegaly, patient is having breathlessness, liver abscess. You'll get an ultrasound done, there will be some finding. Primarily, but the patient was breathless, neck veins were engorged. So surgery is medicine plus surgery. You must understand this. Because in a patient who's got right-sided failure with pedal edema, you obviously have pedal edema, neck veins engorged, Krebs, and all the other features which I told you. The management is totally different from doing the surgical management. Similarly, a surgeon should also not be just a technician who can fix up one part of the car that is not working. Carburetor खराब है तो carburetor बदल दिया. Brake खराब है, brake बदल दिया. You have to understand the whole car in order to fix a problem in the car. So that is what you require. That's why you have to understand medicine fully before you can practice surgery. The surgeon should be able-minded, able-bodied, weak-minded. That is also wrong. That, you're fit physically, you can stand for 12 hours a day, but you don't have the intellect. You won't make a surgeon. The surgery demands understanding of medicine. I told you just offhand the right heart failure. It is, you can extrapolate it. That's the end of the story actually. Similarly, aortic stenosis. I told you one stenosis, one incompetence. Let's fix up the other one. Aortic stenosis would be relevant in systole again. Because the systole which will lead to pushing of it. So there will be a murmur. And then in mitral stenosis, I didn't talk to you about the whiplash, murmur, whiplash sound, where the valve is hardened. Right? In the aortic incompetence, you have the leak back. You have the pistol short murmurs in the femoral where you can palpate for them. You can, D for distal, D for diastolic. Press it distally, in the diastole you will hear the murmur. So that is all connected. You have to understand, you should have a bird eye view of the whole thing before you fix one little problem also. The option, the choice is yours. You can do without it because you may be called upon to fix an appendix. But that's not how you should look at it. He may have appendicitis but may also have other problems. Here, usually in a big center like ours, this referral business gets a little mixed up. You think there is a medical problem, the patient as a whole has a problem. About the breaks. Like I was telling you, it's not about I am a thumb surgeon, I am a little finger surgeon and a terminal surgeon who is terminally waiting to disappear. So imagine the patient as one entity. Then you can fix one part, not otherwise. Aortic stenosis, I told you, usually happens in atherosclerosis, narrowing. Incompetence happens in one of them, even in atherosclerosis. See, all stenosis can also lead to incompetence. Mitral stenosis leads to also incompetence, which is functional. How? You're all tigers in medicine.
There will be less blood in the left ventricle.
The moment you start, they go wild guessing. When there is mitral stenosis, there is a left atrial hypertrophy. As it keeps on stretching, it stretches the valve. So there is a functional leak. It's not a problem. It's not true incompetence, it is functional incompetence. The same thing happens to the ventricle also. But otherwise, syphilitic aortitis was one factor. And aortic stenosis would have a murmur during what? Systole. And incompetence will have it during diastole, naturally. You just imagine the phase when the leak is happening. That's when the murmur is. Any problem there? Simple. Now keep on extrapolating. You can make a story out of it. It's a little cue I have given. Similarly, when you are dealing with a patient who's got, say, multiple problems, but this also, like aortic stenosis, peripheral vascular disease, general features of atherosclerosis, you know that patient would require general treatment. It's not just one problem. What are the causes of clubbing?
Like COPD can be there, interstitial lung diseases can be there,
Anything can be there.
Any causes that decreases the efficacy of lung and decreases the oxygen?
Speak loudly.
Sir, any cause that decreases the efficacy of lung and decreases the oxygen concentration in blood?
That's very well answered. Learn to answer that way. You guys are mostly about counting the leaves. He was talking about the root, which is what I like. So it's basically about anything that leads to hypoxia of the tissues. So it could be causes, it could be pulmonary, it could be cardiac, it could be GI. You have cirrhosis, SARB, I told you, cervical bacterial endocarditis, which involves the spleen or other places. Pulmonary, you have chronic obstructive lung disease. Chronic bronchitis, lung abscess, they all reduce the oxygenation, isn't it? Then you have cirrhosis of liver, as I mentioned in GI. What about the cardiac causes? All those, anomalies ASD.
Shunting, right, left shunting.
So all the left to right
Left to right.
shunting. So understand it that way. वो अपने आप जवाब उसी में से निकल आते हैं. तो कुछ याद करने का काम नहीं होता. Intelligent people don't have to cram up everybody's phone number. No? They would generally know. नहीं तो हर चीज का वो GPS निकालो. What are the important ones? See, bronchitis, chronic bronchial asthma, bronchogenic carcinoma. Pulmonary, important. Chronic obstructive lung disease. And chronic obstructive lung disease has a triad of three, three circles within each other. Bronchial asthma, emphysema, bronchitis. They are together. They are all together. And that leads to chronic obstructive lung disease. Bronchogenic carcinoma produces a similar problem. Similar problem. Same. ASD, VSD, of course, you know that. Subacute bacterial endocarditis. I told you the triads, remember. So that will produce splinter hemorrhages, clubbing, many things, SABE. But generally it will happen in a pre-existing disease of the valve. So normal valve won't get it.